Hello everyone, I hope you all are doing well. So today's lecture is about lung cancer. Without any further ado, let's get started. It is the most frequently diagnosed major cancer and it is the most common cause of cancer related mortality worldwide. So the risk factor for lung cancer are cigarette smoking, which is the most important risk factor and responsible for at least 90% of lung carcinomas. The death rate in heavy smoker is 40 times that in non-smoker, and passive smoking is responsible for 5% of cases. Other factors include radiation, uranium, asbestos, arsenic, radon, and obviously genetics. So the cancer cell type include small cell lung cancer, which has central location that is near main bronchus, and it is strongly associated with the smoking. It occurs in 20% of the cases of lung cancer and it originates from small immature neuroendocrine cells. Therefore, they produce hormones. Therefore, it causes paraneoplastic syndromes. It has multiple site involvement in lungs and it grows fastly and metastasizes fastly as well. Other cell type is non-small cell cancer, which is a slow growing cancer, and it is of the following subtypes: squamous cell carcinoma, adenocarcinoma, large cell carcinoma, and carcinoid tumor. So these all are types of non-small lung cancer. And squamous cell carcinoma and adenocarcinoma combined form Pancoast tumors, and squamous cell carcinoma is strongly associated with the smoking and it produces keratin and it is the most common cancer. Or adenocarcinoma has peripheral location and it is not associated with the smoking and it generates mucin mainly. Large lung cancer is also peripherally located and it is associated with the smoking. It lacks glandular and squamous differentiation, so that's why it's large cell carcinoma. Carcinoid tumor occurs from mature neuroendocrine cell. The small lung cancer was originating from immature neuroendocrine cells. So the patient with lung cancer will present with cough, which is the most common early symptom. They may also present with hemoptysis, especially in the central bronchial tumor because of the invasion of blood vessel, chest pain, weight loss, shortness of breath, fever, and night sweats. In case of mediastinal spread, the patient may present with hoarseness due to recurrent laryngeal nerve palsy. They may develop dysphagia due to esophageal invasion. Bovine cough can occur because of recurrent laryngeal nerve palsy. It is a cough lacking normal explosive character. Vircho's node can be present, which is a palpable left supraclavicular node. Superior vena cava syndrome can also occur due to compression of the vein superior vena cava by the tumor, and the patient will present with head and neck swelling, conjunctival edema, headache, dilated veins on chest wall. So these will be the features of superior vena cava syndrome. Diaphragmatic paralysis from phrenic nerve invasion can also occur. Bronchial obstruction is also another clinical presentation, and it may be complete obstruction or partial obstruction. The complete obstruction may lead to collapse of the lung and it will present with breathlessness, tracheal deviation towards the affected side, dull percussion note on the affected side, and reduced breath sounds on the affected side. However, the partial obstruction will present with monophonic unilateral wheeze that fails to clear with coughing. Pneumonia and lung abscess may also occur. So these are some local effects of lung cancer. Example, Horner syndrome, which occurs due to involvement of sympathetic chain at or above the level of a stellate ganglion. So it is characterized by ipsilateral partial ptosis, meiosis, and anhidrosis. Anhidrosis is absence of sweating. Ipsilateral partial ptosis means the drooping of eyelid, which will be partial, and meiosis is constricted pupil. Another local effect is Pancoast syndrome, which is mainly because of the apical lung tumors in the superior pulmonary sulcus. Example, adenocarcinoma and squamous cell carcinoma. So it is characterized by pain in the shoulder and inner aspect of arm along with wasting of hand muscles. It is due to damage to the brachial plexus, especially the roots of C8 till T1, and it may be associated with Horner syndrome. Another is hypertrophic pulmonary osteoarthropathy. It refers to periostitis of long bones, tibia, fibula, radius and ulna, and it presents with the pain and tenderness over the affected bones. It may be associated with digital clubbing, and X-ray will reveal subperiosteal newborn formation. Lymphatic
So these are paraneoplastic lymph nodes, which is the most common site, and mediastinal and cervical lymph nodes.
And they secrete
Whereas
hormones,
hematogenesis spread can occur to liver,
hormone
bone, brain, and adrenal
like
glands.
Cushing syndrome because of the secretion of ACTH from small cell cancer, syndrome of inappropriate ADH secretion because of a small lung cancer, Lambert-Eaton myasthenia gravis is associated with the small lung cancer, thrombophlebitis and non-bacterial virus endocarditis are associated with adenocarcinoma, hypercalcemia because of parathyroid hormone related peptide release from a squamous cell, gynecomastia because of gonadotropin release from large cell cancer, digital clubbing and due to non-small cell cancer, dermatomyositis and acanthosis nigricans by all of the cancers. So few investigations that we can perform include chest x-ray. CT scan is useful for detection of small tumors, identifying disease in the mediastinum such as enlarged lymph nodes, local spread of tumors, secondary spread of carcinoma to opposite side of the lung. These all can be detected by CT. PET scan is the investigation of choice for the assessment of mediastinum and possible metastasis. Fiber optic bronchoscopy is used to define bronchial anatomy and to obtain biopsy and cytological specimens, and it is used for centrally located cancers which are near to bronchi. Percutaneous aspiration and biopsy under CT guidance for peripherally located cancers, and most common complication because of this aspiration or biopsy is pneumothorax, iatrogenic pneumothorax. So for the early stages of non-small cell lung cancer, we require surgical resection, which is the main modality, plus adjuvant chemotherapy. And for advanced stage, chemotherapy is the main modality plus radiotherapy. Bevacizumab, which is the antivascular endothelial growth factor antibody, it can increase median survival rate by 2 months. So for small cell lung cancer, which is usually disseminated at presentation, chemotherapy is the primary treatment modality. Radiotherapy can be added to improve survival. Prophylactic cranial irradiation improves survival. So that's it for today's lecture. I hope you learned something from it. If you do, please like and share my video and subscribe to my YouTube channel. Thank you so much for watching.